analytic and observational methods. And Yang Chen is a senior scientist in Daeom at Merck. And then the second, talk about practical experience with the HUMICA issues, limitations, and opportunities. And then the second one will be Chao Zhen from UNC, a doctoral student, new user design and missing scripts. And the last one will be, in this session, will be Alan Brookhart, an associate professor at UNC, talking about linking claims and EMR. And let me get the right presentation up. Robert, and we can start. Okay, thank you.
Thanks, Cindy. So I'm just going to give some practical experience working with electronic medical records here at Merck. That is the data issues, the limitations, and opportunities with Medica, the Medica that we do have in-house as an demonstration illustration. This is the overview of how the speech is going to be, the talk is going to be. That is electronic medical records, databases. The in-house EMR resources that we have at Merck, there's some limitations. There that I'll go into the experience we've had so far with HUMICA. Then Chen Yong will be going to look at his beta assessment of HbA1c among patients initiating sulfonylurea and metformin in claims and medical EMR. I'll first give kind of just an overview of the EMR characteristics of the EMR databases. To understand EMRs better, it's a good one to know exactly how they're generated or how they come to be. The key thing here to get is information, whatever information that is captured in a patient record, that is patient healthcare record, that is what is in the EMR. The main purpose of EMR generation is patient care. And as you can see here, all the data with the computerization of the healthcare record keeping system, information is entered into some kind of platform or servers, a network of servers. So this information ranges all the way from the patient clinics, hospitals, labs, labs, and and also imaging centers. So this is from the perspective of the treating clinician or medical care worker, and it captures all patient healthcare activity, and this does include office visits, procedures, patient complaints, treatment histories, vital signs, lab, as I already said, the insurance of the past of the patients in some cases, and that is. Mark, we do have quite a number of EMRs, and we quite a number because the way the data in the EMR is captured is dependent on the healthcare system or setup of the way the data is captured. Hence, the two big buckets that we may have are the US databases and the UK, for the Europe one from UK, and these stem from the two different health systems. But within the US, because different EMRs work or the data systems are different, we also get different flavors of EMRs. For example, we do have here geocentricity, which sometimes is called QUILs. This is mainly outpatient or physician. Most of the data there is physician-centered. We have Sana Health Facts, which is mainly hospital data. It does have a combination of both clinic, physician, and also hospital information. Recently, we did acquire Premier. In the Kingdom, we do have these two, THEAN and CPRD. They're similar, but some some business reasons that we do have both of them. With the strengths and weaknesses of the EMRs, first strength, the biggest strength of the EMRs is the richness of the clinical data. They do capture all the labs, vital signs, body measurements, lab size observation, for example, smoking, which if we have to compare them with claims, is not the case, or claims is not this rich as far as clinical data is concerned. On continuum of care, EMRs tend to capture more care or treatments, from the prescriptions and also the inpatient administered or hospital administered medications or treatments. The strength of EMRs and what we are working on to explore through a number of avenues is the physician notes. Of course, and present in the claims databases. We do offer an eye into the patient or physician interaction and corresponding ability to capture a wide range of information from evaluations not present in structured data inputs. And this may include signs and symptoms, other physician rationale, including why it was prescribing a given medication. As I mentioned before, we are trying to use these physician notes for natural language processing, NLP, to translate raw physician notes into structured data fields for signs, diseases, symptoms, family history, and also trying to capture drug behavior, for example, why someone switched or stopped taking a medication. For the limitations, I'll be comparing it mainly with the claims databases. They're incomplete in a way and inconsistent because, as I said before, that they are not built for billing purposes, so they are not that structured as required in the claims, such that if the claims aren't filled in correctly, that the reimbursement or the payment won't be done. So this has a varying degree of completeness. This depends on the provider group. The providers have different computer systems which capture this data. And with, for example, you can find that the matter want to bring all the databases together. You may find that the kind of system working at the EMR or the ones working in the hospitals might not be exactly the same, or they might not link properly, which is in the physician offices. Another limitation that we face is the incomplete enrollment information. Do capture encounters with healthcare providers within one system, such that when a patient goes inside this system, that system doesn't, wherever the patient has gone, that system doesn't capture, isn't entered to the EMR that you're looking at. The information is gained. So that follow-up duration, working on a study where follow-up is quite important. You may know exactly when the patient stopped treatment, when to stop tracking that patient in your study. So that's a big limitation. So despite all the richness of the data, but if you're not sure if the patient is still in the system, if you've still captured everything, you may run into problems. The other limitation is regarding the prescriptions. You capture very good prescription information. However, we can never be sure whether that prescription was filled. Let's have quite a number of drug coding. For example, it's not that structured that a physician won't be back that you have to use this coding system. There are quite a number of physician depending on the provider. The coding systems of the different drugs may be different, such that at the end of the day, some of the descriptive features may miss. For example, strength of those of the prescription. The diagnosis. One of the claims where the diagnosis has to be has to align with what a physician is billing for. In the ERs, it doesn't have to be that way. So that in these cases, diagnosis has it's no doubt that this is a primary diagnosis, and the others are the secondary. So that also may create, as you track the diagnosis of the patient, could be a limitation. Regarding for those who are working with projects which do require cost information, this is not as well captured as it claims, because it's not a primary purpose, or it's not at all linked to what data is collected. It's mainly for patient care. So less than half of all the patients will have charge records in most cases. So, medical experiment. As I said, we do have quite a number of EMR databases at Merck, and we did sort it fit to have it in at least. This is the first year. I think in a few months it will be our first year that the anniversary that we've had data. One of the things that really let's bring it in was the richness of this data. Of course, most of the information we get it from the vendor. They do have quite, they've done so far. What we do appreciate is that did capture data, their data from quite a number of sources. And with that came the big concern of cleanliness. As I said before, not all systems are the same, and in the process of bringing these databases together, cleanliness was a big concern, and we brought it to them that and they did respond to doing some of that, or some of the consultants that we have, by going over the different methods they use to make sure that we get a clean product. One of the procedures is standardization, in that they try to make sure that all they have consistent business terms of how different terms are defined. They also do variations. This, as you know, of the data, there could be some errors. For example, they do try to clean out if there are some out of the range, for example, patient recordings, or it could be in some cases whereby the dates don't make that much sense. For example, when the discharge date is before the patient date. We also when we get this data in-house, we do quite a number of QC processes. This one is during the load of the data, where we try to make sure that we've loaded what the vendor intended to send us. We do request that they have some parameters to compare with what they have on their servers. But on top of that, we also, what we are trying to work right now is to do some in-house validation to make sure that they just don't go by what they sell us or what they tell us, but make sure that all their data it makes sense. So that's one of the challenges that we have. Come with a system of validating their data to make sure that it's as clean as the vendor, given the robustness of the data to make sure it's as clean as they say. Humedica it's EMR, but it has its advantages over the EMRs. Of course, as before, it's clinical robustness. On top of that, they managed to create or to enhance their data, whereby, in addition to the standard diagnosis information, they create a number of flags. For example, admission, they did create their own medical flags. For example, the admission diagnosis flag, discharge diagnosis flag. I said earlier, they are not by default in the EMRs. Another thing that they've improved or they have in their data is microbiology results. This isn't common in the other. We do have the test, that the test was ordered, but the microbiology results in Humedica are superior than in any of the EMRs we have. They also have, in addition to the typical EMR drug information, they managed to get or they have in their data derived NDC codes, or they try to go into the data and derive NDC codes. They are not so specific or as the ones that you may find in the clinical databases, but just derived and they do some of the purpose. And of course, as I showed earlier, they do have good natural language processing resources. They do offer some trainings, and this they do provide quite a list of terms which we could use to enhance some of the outcomes that we may be looking at. For example, recently, just this week, they did give us some cancer-related terms that they've worked on, so that we're working with this data. We don't have to do the NLP ourselves, but we could use data already done. Of course, one of the questions that we had for them is whether some of the terms which have been derived, NLP terms by them, but they told us that they've done some of their in-house validation, but we need to see. That's something that we have to check on to make sure. Maybe what we have to do is to do some in-house validation also, just to make sure that the system works fine. So, just to make sure that we use the data appropriately, we set up quite a number of trainings to make that we do have OMDB here, which stands for One Map Database platform, and where all our observation databases are stored. So we had a kickoff training for OMDB users, and after the initial database was installed, we've had recurring monthly check-in meetings with a team from Humedica. And this is where we're very helpful in that there were some people, some groups which were working on studies, and they wanted some help with how best to define an outcome of interest. And the Humedica team was very helpful. For that, we do have quarterly training meetings, which coincides with new releases. We do update our medical database every quarter, and this offers a venue to share learnings between Mark's team and the medical analysts. As far as the projects are concerned, there was a slow uptake of the use of this database, because we had some MRs in-house, and some people were, because they were comfortable with that, with the MRs that we had. However, with time, we managed to have quite a number. The number of projects has gone up steadily, whereby, of course, the most in the beginning, most of them were more of we had full projects as such, but there were more of kind of feasibility analysis. I one that is going to be presented by Yong. So with that, I would like to give over to Yong to present the next set of slides.
So we'll have Q&A after Yong, because he's presentations tie together.
I think a very good overview of the difference between claims and EMR. So I'm just going to present a simple exploration of medical data in-house. The title is Feasibility Assessment to A1C Data Capture among patients initiating sulfonylurea and metformin in claims and EMR. So give some background, additional background. Commercial claims database is the most commonly used database for us to conduct real-world observational research. Due to the nature of claims, has billing codes that physicians, pharmacists, and hospitals and the other healthcare providers submit to those records. A lot of clinical data is not available or incomplete in a commercial claims database. And in addition to database, we also use EMR, Medica, to conduct observational studies. EMR is collected at the point of care, which means patients use this information to diagnose and provide treatment to patients during the encounters. And it has rich clinical data, including signs, symptoms, laboratory data, BMI. It also includes a population with a broad range of age. A lot of commercial database has employment-based, so the age is relatively younger. However, EMR does not restrict to this type of population, so it may include greater than 65 years old. And also, it may include patients without health insurance. And so, the difference between, we know the difference between claims and EMR, and we have this opportunity to put the Humanica database in-house. So we're interested in to quantify how much the difference between the two databases in terms of laboratory data capture. And HbA1c is one of the in our diabetes franchise. Did a simple exercise to compare A1c laboratory data capture in patients initiating sulfonylurea as an add-on therapy to metformin between claim database and an EMR database. The database which use is the Optimum Informatics Data Mart, shown Optum, and now we use a Humanica. So the patient we select for this analysis is those who initiate sulfonylurea as an add-on treatment therapy to metformin after 2000. Because the reason we choose 2000 because Optum data starts from 2000, and we define sulfonylurea as an add-on treatment as to after metformin prescription prior to the sulfonylurea prescription, and its date of supply also overlaps with the sulfonylurea prescription. And we restrict to patients with at least 1 year based on continuous eligibility. This is relatively easy to be done in claims data. For EMR, we don't have enrollment information, so we thought to just use healthcare encounter to count continuous healthcare interaction patients with the healthcare system. So we use encounters within 0 to 6 months, and so the patient should have at least one healthcare encounter within 2 to 6 months, and between 7 to 12 months prior to the sulfonylurea prescription date. And also, 3 patients who have at least HbA1c results within 1 year, plus minus 1 year of the index date. And the patient also have an A1C data with 3 months prior to the index date to set as the baseline A1C. And the baseline A1C should be between 6.5 to 20. To make sure the patient has therapy, we exclude any anti-diabetic medication except for metformin within 90 days prior to index date. So since it's a very simple CT analysis, we just conducted the descriptive statistics. This is the results. So what we found was in Medica, we found about 380,000 patients in sulfonylurea, and among which about 100,000 are dual therapy, and about 40,000 patients have at least 1 year eligibility. Compared to Humedica, Optum has significantly higher number for the first 3 rows. So we found about 860,000 sulfonylurea initiators, about 29,000 dual therapy initiators, and about 100,000 have at least 1 year baseline eligibility. Applying the A1C criteria, the numbers is totally reversed. I can see that about 9% of Humedica patients have at least 1 HbA1c lab with plus minus 1 year of the next state. Only 33% of the Optum patients have an HbA1c lab. Further look at with HbA1c pre-index and about 6.5 to 20, about 50% in Humedica and 14%, about 15% in Optimum. And look at the A1C data over time with criteria. The number for Humedica goes down to 27% for patients with at least 1. This line. For at least 1 pre-index A1C and at least 1 post-index, it will be around 20 weeks, and 1 post-index A1C around 52 weeks. And for this, the more restricted criteria, Optum only has about 3.6% of patients with these A1C data over time. An interesting thing is Medica, as I mentioned before, it may include a broad range of age population. So we can see among the most restricted criteria, we have about 7,000 patients who are younger than 65 years old, and about 5,000. So it's basically half-half. However, for Optimum, most of them are younger than 65 years old. Only few are older than or equal to 65 years old. Another thing we can see is this is a A1C distribution in patients in 2 different databases. The figure on the left is for Humedica, and the figure on the right is for Optum. You see the mean and median A1C in Humedica is much smaller than the mean and the median for Optum. I'm quite figure out why this is the case. Maybe it's because the difference between the year and the claims selection. Maybe it's because of the sample size. But there's a difference between EMR and claims. Discussion. So what we learned from this simple data exploration, we found there's some strengths of EMR. For example, it has lab values and a much better lab data capture, and it's over time. And we also look at BMI, so it's not, the same amount of BMI among the patients we identified in this study. Approximately 90% of the patients in EMR has actually BMI data at some point in their life. And for Optum, there's no BMI information in the claims. And also challenges for EMR is some challenges are similar to what we have in claims data. For example, drug names, missing NDC code, GPI code. Some drugs has drug name, no NDC code. Some drug has NDC codes but no drug name. So it might be useful to just identify drugs using all possible options. I think days of supply, which is common in both claims and the EMR. The most important with for EMR is that we don't have enrollment information, so you have to use some sort of to estimate continuous eligibility and the continuous follow-up. For HUDA, all labs are standardized. A1C is very common in research, so they provide this information. But for some rare laboratory tests, they may not have some information. And the lab value, as usual, it's a mix of numeric character values. It may need significant time to clean them up. So in conclusion, comparing with claims data, EMR data provide relatively better A1C information, and since the weakness, of EMR needs to be considered carefully when designing an additional study.
Great, thank you. And Robert, if you could come up, we can have questions about this patient.
I have a question for Yang about the lab data. The kind of dates do you have? Are the dates the lab get ordered, or the days when the results got reported?
I think the days of the results. When the physician reads the results, they put into the EMR system.
Thank
you. That's a very good job. One question I have is that when you look at your 2000 data, I know that 14 years ago, most of the health plans are trying to collect the lab results into their database, but because of contracting issues, they did not get involved. Having the similar sort of in recent years, let's say 2010, 11, or something like that.
Well, this data including from 2000 to 2013.
Well,
I didn't restrict to 2006.
Okay.
But I don't expect it might be significant increase in lab data in claims in Optum. Going with 33% to 90%, I think there's still probably still smaller than.
Yeah, I think it would be very helpful if you can give us a time frame. So in the early years, maybe much smaller,
right.
And later years, maybe say last year, the year before.
Good idea.
Yeah, I think that will give us, because we don't use this kind of old data anymore. We use more recent data for many of our studies. Thank you.
Okay, thanks.
Joe from Merck. Just one curious question about the difference of A1C level between the EMR database and the claim database. So I assume you're going to look at the patient demographic difference. So curious, did you also say in the claim database that maybe patients who have a claim maybe tend to be more severe case? Is that a fair assumption or not?
Yes, one of the we're thinking of, especially for EMR comparing with Humedica and GE. So GE usually collects information from, large academic medical centers. So we may have, relatively severe patients compared with Humedica, which collects information from both, integrated health system and small physician groups. We may include, a relatively broader patient population, but it's to an EMR comparison. But for EMR and claims, it's possible, but how to verify them? Maybe just looking at patient characteristics.
Yeah. I have a question for Robert while I'm walking. You mentioned that there's not as much dosing information in the Humatica database. How do you think might be in the physician notes that it's just structured?
You're right that there isn't enough information, and that's why we are now trying to use NLP to see if we can use it to get as much of the numbers from the dots to at least to use together with what we have already in the EMR. That is the one structure so far. So.
I'd like to come back to this issue of a curious, almost counterintuitive finding where we're seeing this distinction in the claim data for the A1Cs. Understanding is the main determinant of whether a lab value gets into the Optum data set or not is an accident of the low contracting with the reference lab, and if they do the local plan contracts with a national reference lab, they require them to feed that information back to them automatically. So that suggests that we didn't expect a copy of that it would be representative if that was just a random thing or unrelated to the patients. With that in mind, I'm wondering where you've entertained the idea of look within claims, identifying those who had a claim for the test and looking and dividing them into those where you had results and didn't have results, and seeing if there were demographic or other differences in terms of markers of their health.
Yeah, that's a good suggestion.
Can we go on to the next talk?
I have another observation that we saw significant numbers of the older populations greater than 65 years old on EMR. I think as observed from the study cohort, it could be possible that of A1C could be higher among the older population because we have a big proportion of it.
Yeah, but the thing is, EMR has a lower mean and a median HR, A1C claims. They have higher patients who are older.
Excuse?
Okay, thanks, Young and Robert, for the great introduction on the EMR data. And I think this is very enlightening to this next topic about new user design and missing drug information. I think most of you have more experience than me about dealing with EMR data. So when I go through the material, I would like you to keep this question on missing data in mind, and think based on the travel experience or based on what we just learned to see if we can use EMR to tackle this missing drug information. So about user design, I think most of us are not new users to this design, so I'm not going to go into details. I think this design has been like default study design for pharmacoepidemiology research and other observational research. And you have this goal to assess the effect or safety profile of a medication or conduct studies, and start with this population who take these drugs and they develop some kind of event down the road. And you're asking this question, how to select this cohort and from what day you're going to start follow-up. So for the current or prevalent user design, you may be selecting patients who are on treatment for a while, and you may select me miss some of these early events at the beginning. With this design, you have running this trouble, so you're missing these early events, and you also when you are controlling for covariates, consider based on actually these covariates have been modified by previous treatment, so you result in bias. With that, it looks like it's not a very good idea to use these prevalent or current user design, and that's why we started to think about new user design. With this secondary databases, we're going to look at trying to align your study design with this occurrence of these events. So we use these prescription fields. Actually, the first word, you have these different modifications to this new user design. But for this is a really simple claim here. So you have the first prescription field and use that as date where they initiate the drug, and index date, and then you start following them from that day. So you're likely to have a fair representation of early and later events, and you also avoid the potential to adjust for causal intermediates, and also have this potential for you to control for time confounding. Also, some trade-offs. The disadvantages of this new user design is because of this restriction, reaching in sample size, so you may have this loss of power. Sometimes it's just simply hard to apply this design, and especially about the time of initiation. So this is kind of a great challenge in observational research using secondary databases, and it is with this design are the patients identified with healthcare claims databases, are they true new users? A transition of this question is, are these pharmacy claims data used to conduct this study, are they complete to capture every information you needed? The great, the rising concern about the completeness of pharmacy claims databases. There are multiple convenient sources for this incompleteness, that including patients paying cash for these drug medications, and who have used these drugs in an inpatient stay, or they use their spouse from benefit to get these medications, or receive mail orders from outside of the U.S. So you wouldn't have this kind of information in the claims. And also there's another source, which is free sample use. There are multiple studies at UNC have been shown evidence for missing drug information. And check these references here. And today I'm going to focus on study which for free sample use. So free sample use it has been widely used in the United States, and using as a market or due to other philanthropic reasons, it has been widely distributed by pharmaceutical companies. In 2010, there was about $14 million spent on samples. Free samples are also considerably distributed by physicians to find the optimum dose or treatment or initiate these patients on a long-term treatment, and also give patients an opportunity to start treatment right away. But different people have different opinions towards the free samples. How it's agreeing for us, for researchers using this data. Because of these free samples, there's no record sent to pharmacy benefit managers, so there's no record in the claims. That would result in exposure misclassification when we use these claims data to identify new users. And because of there's no record in the claims, it's really hard to study these free samples or to find evidence for these free samples using claims data directly. Like this, I like to think that it's like to ask people who are in a room to raise their hand. If you are not in the room, so it's really hard to study that question here. So traditional methods fail here, and we need to find a novel study design methods to evaluate that. In this study, we try to come up with a novel design to assess the extent of free sample use in U.S. commercial claims databases. And specifically, we estimate the prevalence of sample use using statin initiators and LDL lab results. Statins are good candidates for this study due to several reasons. First, statins are cholesterol-lowering drugs. They are known to be very effective at lowering LDL. They have a complex treatment algorithm depending on risk categories, with the goal aiming at below 100 milligrams per deciliter. Most of them wouldn't initiate statins when they're until LDL exceeds 50 milligrams per deciliter, but patients who have LDL between 100 and 129, they may initiate LDL. Also, the treatment of statins LDL are recommended to regular monitoring this treatment. And another reason of using statins here is it is one of the most commonly prescribed medications. And between 2007 and 2010, there are a lot of brand and generic drugs on the market, and it has been reported that statins is one of the most frequently reported drug samples distributed. So we adopted a commonly used new user design to select a cohort of statin initiators in market scan data from 2007 and 2010. So we them to have at least one fill of statins, and they need to be at least 40 years old at initiation. And prior to this first prescription fill, we require them to have this 6-month work period, so free of statins. In addition to that, we require them to have at least one L lab before the fill of prescription, and with the LDL being happening within these 15 days prior to prescription fill. So we think this LDL should be triggering the statin initiation. So with this design, we're likely to capture both newly new users and those users being treated by free samples. Their LDL dropping, that's why they're smelling. Then the users will have this set base. So for the newly new users, this is we have this LDL prior to statins, and this LDL should be the pre-treatment LDL. And for the patients have already been treated, this LDL happening after the free samples, and it will be post-treatment LDL. Again, we have these records of free samples in claims, but we do have LDL results and also the prescription fill in the claims data. So if we have these, if the patients we selected are all new treated patients, their LDL should follow a normal distribution. And if some patients have been already treated through free samples, we'll have a mixture of treated and also those patients who have been treated without samples. Then we just saw prior to the prescription field will follow mixture distribution because statins are so effective at lowering LDL. So the patients who have been treated, their LDL should follow, should have this lower mean on the left. We analyze their treatment LDL using a mixture model. This is the two-component Gaussian mixture model. Here, the P stands for, how can I go back? Here, the P is the mixing proportion, will give us the estimate of the prevalence of sample use, and mu's are the means, and sigmas are standard deviations. The mixed model analysis provides statistical inference for the unknown population, given only the pooled population information. So this mixed model will provide these estimates for these using a maximum likelihood approach to get the estimate. We analyze these LDL in branded versus generic separately because those are likely to be given for these branded medications. They're more expensive. And so focusing on this LDL prior to the statin fill, on the left here, showing it for the among branded drug users. On the axis is the LDL in milligram per deciliter, and the y-axis is the density. And the dashed line you're showing here is the density probability for the overall population. And the two curves demonstrate the two underlying population here, with the red one referring to the one with the lower mean. And we see here the green one has a mean around 148, and the red one has a mean of around 72. Just to show that the treatment of statins wouldn't be initiated for patients who have at least until LDL exceeds 130 milligrams per deciliter, and with some of them may initiate between 100 and 129. So these portion of these patients with LDL well below this 100 milligram per deciliter, and with that, they may likely to have already been treated. And so this is showing the branded drug users, and among the generic drug users, this apparently modality just disappeared, and we have seen a more homogeneous distribution of LDL here. So this contrast between brand versus generic give us a great evidence that showing some of these patients, if initiated branded drugs, they have been treated well free samples, and about 1 in 7 initiators, which is not just a amount. And when we look at patients who have at least 2 more labs, 2 labs before statin initiation, we found out 25.6, which is in 4 patients may have already been initiated both before the first statin treatment. So this contributing a compelling evidence towards free sample use among initiated branded statins, and the results have been shown to be consistent with other studies on drug information at UNC. These findings have great implications for pharmacoepidemiology studies using these claims databases. So we've seen that it's likely the date of initiation may misclassified, resulting in these exposure misclassification, and we're likely to miss some early outcomes. And this is matched to people who conduct safety studies, and like the mini sentinel by FDA when they monitored drug safety study using sector basis, and they may need to have this kind of exposure misclassification. And also, the message for studies employing this case-only design with this exposure being misclassified, you may have a really biased estimate in not going into the opposite direction. And also, we're showing that some of these LDL have been already modified by treatment well free samples. So if you're using LDL as one of the variables to control for confounding, you're actually controlling for intermediates, which will result in bias. And just as we talked about earlier about adherence and all that, I think this also that using data, and some of these patients may be here, but actually they're adhere to the treatment regimen, the guidelines. There are some things we need to. One is the generalizability, because we use these commercial claims databases, which may have a different sample use in this population. If we look at Medicare or some other databases, we have a different result. So we cannot just apply this proportion directly to other databases for other populations. And also, different drugs have different promotion expenses. So the different drug class, you may have a different proportion of sample use. There are other possible explanations for this mixture distribution, and we have gone through all of them really carefully, and we conclude that actually sample use is the most plausible explanation for this mixture distribution. And we have conducted several sensitivity analysis by including people who had diabetics, which were shown to get LDL initial status at a lower LDL, but we didn't find any changes in these results. So likely sample use is the most probable explanation for this mixture distribution. So we have shown these compelling evidence for sample use. However, it's not indirect evidence because we cannot directly assess that. And then my question to you all is, we directly assess this sample use using EMR is feasible, and have more experience than I do. Just wondered, are the sample use being captured in EMR, and what kind of information have been provided in these EMR results? The one of variables do have durations for these free sample use, for these free samples to be distributed, and are there any missing data and all? So that's what I have, and I'd like to see your thoughts on that.
Thanks. Questions? Comments? Thoughts? Dan?
There are some practices that systematically don't participate. There are some practices that systematically don't accept samples from drug companies, and sometimes these practices can be identified. The parent organization they're part of had a policy, and for example, there's some university hospitals that just have a blanket policy of not doing this. I'm wondering whether you've thought about teasing this out. What you're seeing is true. You might expect this, it's almost like a quasi-experimental situation where you have practices that just don't sample, and you would predict that you wouldn't see this phenomenon.
Yeah, there are a lot of, especially university-related systems that they say no to samples, and I think there's more healthcare systems are starting to have that. I'm not sure in this data since we use market scan in this study, so I'm not sure we could tease that information out, but if we have that, we can definitely see. I think it will be a good control to show our math work if we're looking at that price to see if there's still a bimodal distribution or not. Yeah, that's a good question. Thank you.
With the natural language processing and stuff, there may be an opportunity to look and see, just describe if there's any sample, like after that within the notes. I don't know if that's available. In much detail, it's like sample given, and it's like, do they have the dose? Do they have the, how many, that type of stuff. I don't know if that. I'm just thinking here that may be an opportunity for you to look into that.
Yeah.
I think that would be of interest to a lot of people.
Yeah, but claims we could not get that information. That's why I'm thinking if we have these electronic medical records, if they capture that information in the charts, we'll be able to directly assess that. Kelly?
Yeah, congratulations on this really wonderful presentation. Thought that it was a very clever idea to use LDL data and to look at the free sample giving pattern for statin. But I'm just kind of curious that this practice might not be all that similar across different therapeutic areas. And I'm wondering that, this is a very clever idea to look at LDL and the lab results. And wonder that, have you ever thought about other therapeutic areas that are other labs that are looking into this, because the sample giving patterns might be a little different?
Yeah, that's a good question or suggestion to these. I think there are other therapeutic areas when they have these routine monitoring, especially looking at these lab data to monitor the treatment. And I think it's possible to employ this method in that setting. But for some of the other medications, actually we wouldn't know how to do that. And I think there are multiple ways, and actually that's what we're trying to work on, is to how to improve this user design when we know this problem exists. Several ways we can suggest to kind of get around that, but I cannot offer a direct solution for this question. But we can first we have these. For the labs may have this regular monitoring, we can look at the labs. And for some other medications, we can look at office visit, and when they make to the physicians, and then we can kind of look at the trend and also employ that, modify your study design. For some other medications, I think you may kind of restrict a certain area after the prescription fill. So I think this is an area we want to do more research and provide more solution evaluation for that.
One more? Oh, no. Very interesting study. Have you also considered using data source to see if these findings can hold in another database?
Why we choose market scan is because we have this great opportunity to have this lab data along with these claims data. We have that for other databases that if you have all the databases that may offer these a video of both lab and claims, I would love to know that and then do some follow-up study.
Maybe a break.
Yeah. Okay. So.
Did you end at 2?
What?
Did you want to end at 2?
2:15.
Okay.
But we'll take time for questions. We're very short.
Here. Good afternoon. Just want to Cindy and more local GSK folks for organizing this. It's really a treat for us to come here and hear from you and get to know all of you better. So we heard from Robert and Young earlier about EMR data. I think that's a really exciting development in our field, the increasing availability of these big clinical databases. They clearly have limitations, and I think the obvious next step with these data is to link them to claims, right? Because we see things that are happening outside of the clinic. And we've done this in a very sort of select population. I'll tell you about some sort of work in progress, some very preliminary work using these clinical data that we've linked to administrative data. So the exciting thing about the EMR data from my perspective is that it gives the ability to do a much better job controlling confounding. So that's sort of the number one thing that I'm excited about. But other stuff as well, right? We can identify subgroups using lab values that we wouldn't be able to identify in typical claims data, like patients with chronic kidney disease. They're very hard to identify in claims. We've got to do a better job of measuring exposure. So Xiao Wen's been talking about that. So we may be able to use information in the EMR, in the clinical data, to assess exposure better. Possibly we could assess outcomes better. So there's a lot of ways that these clinical data may improve our studies, I think. One potential limitation, and I just sort of started thinking about this recently, is generalizability, right? So we have data on this relatively select subgroup of patients who have both clinical data and linked claim data, and they may be representative of the overall population that we're interested in. I'll talk a little bit about a method that we've been sort of playing with. It's nothing new, but this application I think is new. I may address that, and I'll talk about some of our experiences that I think may be relevant to you in this database. So essentially, we propose to use what's called inverse probability of selection weighting to deal with this kind of missing data problem, right? We have data on this select subsample, and we have data on the rest of the population. And essentially, this is perfectly analogous to like survey sampling weights or inverse probability of treatment weights, where essentially we build a model using the full data that's the probability that a patient will be in our linked subcohort. And then we rate everyone in the subcohort by 1 over this probability. The people who are likely to be in the subcohort are essentially overrepresented, and they can get weighted down relative to patients in the subcohort who are likely to be in it. And patients get weighted up. So reweighting these patients to try to make them look like the overall population. It's a very intuitive kind of approach. And again, it's perfectly analogous to survey sampling. Some of the assumptions that we need to make, we need to have essentially all covariates in the model that induce significant heterogeneity in our treatment effect estimate. It's sufficient, in fact, to have all covariates in the model that are related to the outcome and the probability of selection, but that's a stronger assumption. We also need sort of a positivity assumption. We need that everyone has some positive probability of being in the subcohort. So if there are patients who can't possibly be represented in that subcohort, then we can't talk about a treatment affecting the overall population. And then we also need to get the models right, as always. And we need to use kind of EE or robust methods, stats methods, to standard errors correct to deal with this, deal with the weights. So the setting that I do most of my research in is a population of patients with end-stage renal disease. And if you were at our gig last year, you heard me talk about these guys. But these are patients whose kidneys failed, and to stay alive, they need to receive chronic hemodialysis. The specific area that I'm interested in is anemia management in these patients. So they all, untreated, would have really severe anemia secondary to their kidney disease, and they receive erythropoietin or EPO and intravenous iron to manage this anemia. And so I'm doing studies of both of these drugs, but particularly of IV iron. And so this is sort of the example study that I'll talk a little bit about for the remainder of this session. So essentially, the goal is to look at whether IV iron increases the short-term risk of mortality in these patients, whether a high dose of iron increases their mortality risk. And so I want to do a few things. I first want to assess the exposure measures in the clinical data compared to the administrative data to see how consistent they are. I also want to see how much control compare confounding control in the full link data to confounding control using just administrative covariance. How much additional confounding control we achieve by using these clinical variables. I'll also apply this selection, inverse probability of selection weighted method as an example. So the clinical data comes from DITA, a large chain provider of dialysis in the U.S. They have about 1,500 clinics. They manage about a third of the dialysis patients in the U.S. We have these patients are incredibly medicalized. They're in for dialysis several times a week. So we get at every visit. Labs about every 2 weeks. We get clinical variables recorded when they're in the clinic, blood pressure, for example. Microbiology, these patients often develop infections, and so blood cultures are taken to guide it. So we get data on the microbiology, what kind of organisms are found in the blood. Also, we're now collecting quality of life data quarterly, so we also get measured quality of life. These data have been merged with CMS data, so all dialysis patients are eligible for Medicare benefits. So we've merged this big clinical database with the Medicare CMS data, and we see things that happen outside of the clinic in the Medicare data. So if patients are receiving treatment at another dialysis center, we would see that. We wouldn't get all the clinical data, but we'd at least see that they were receiving treatment elsewhere. If they're hospitalized, we would see that. Now that information does get entered back into the DaVita system, just like I think it would in the EMR system we heard about earlier, but that's done sort of manually, so it's probably somewhat reliable. So the CMS bills for hospitalization are probably more reliable measure of being in the hospital. We get the prescription drug claims, Part D claims from MS data. We get cause of death, date of death, some date of transplant when they receive a kidney transplant. There's a lot of blind data that are collected as well on this thing called the medical evidence form. So the two databases that we put together to do our study. Essentially, we have essentially a new user design. Iron treatment decisions occur after iron labs are taken. And interesting, our data, unlike the EHR data we heard about earlier, the date in the date is the date of the lab draw. And it's all labs are sent to a central laboratory for testing, and it takes several days for the results to come back into the clinical data system, which is actually kind of interesting because usually the clinician knows things that we don't, right? And so we're struggling because we'd have some key piece of information that the physician is using to make treatment decisions. But this, retrospectively, we know something the physician doesn't. The patient's hemoglobin or albumin on the given day, the clinician figure it out for a few more days. So it's kind of interesting reversal of roles there. So we've designed a very simple cohort study where we have iron labs that are drawn and an exposure period that occurs after the iron labs available. We assess exposure and then look at how that relates to outcomes occurring during a 3-month follow-up period. And on the patient, we have multiple kind of dosing intervals. It's kind of repeated measures designed. So we get iron exposure data in both the clinical system as well as from the administrative data. We're using a logistic regression model to predict probability of being in the subcohort. And we're looking at the outcomes in this setting just using Cox regression with weights that are derived from this selection model. A variety of we're considering from the administrative data, from the U.S. renal data system, typical kind of variables that we can get from claims data, and then with the variables as well that we're getting from the clinical database. And very hard to see, but interestingly, there's very little difference actually between these two populations. Mostly, it's visual differences, to be not perfectly nationally representative, but it's very similar. There are a few things that are a little bit different, but there's basically not much difference. So, though I think in some settings you may see big differences between your matched population, the overall population. Here we don't see much difference. And this is just plotting the probability of cohort membership, subcohort membership in different groups. So the green line is the probability, the density of the probabilities in the subcohort. And then when we reach those, and that looks quite a bit like the distribution of probabilities in the overall population. So basically showing us that this reading is working reasonably. So this is very similar to the kind of propensity score curves that we often look at. This is quite interesting, I think. And it has relevance beyond the dialysis population. So we see actually that the two exposure measures aren't very congruent. In fact, we see that often when have a low dose of iron in the DaVita data, they have a high dose of iron as assessed in the administrative data. Turns out that you can only bill for vials of iron, so you can bill for 100 milligrams of iron, but patients often get 25 milligrams or something. So some iron is discarded, and so I think that's the reason for this, which is a perfectly legitimate thing to do. It's not fraud, but I think it's what's going on here. So there's considerable disagreement between these two measures of exposure between these databases. Here's some results, and so the main thing I want you to look at. Let me see if I get a mouse up here. There we go. Are these numbers here? So we've got a variety of things in this table. We have different ways of assess exposure using the clinical data, using the administrative data, and then we have different cohorts. We have the overall cohort, and then we have the subcohort, and then different ways of controlling for confounding. We can control for confounding using just the administrative variables, the claims-based variables, or the claims variables supplemented with the administrative variables. And so, if you look at this lower panel here, these are the unweighted, right? The selection issue here. But we that receipt of a high dose of iron is associated with an increased risk of mortality, 30% increased risk. Just for the claims-based variables, we equate that, but it's still suggesting an increase in risk. And then we have the additional clinical variables, the lab variables and whatnot, that equates basically to the null. So we see improved confounding control in this setting using the clinical variables. When we do these selection weights, we don't really see any meaningful change in the estimates. The confidence interval is a little bit wider, which is not surprising. But basically, there doesn't appear to be much effect on the estimates using these kind of selection weights. These are kind of these are estimates in the overall, in the subcohort, but using the exposure that comes from the claims data, the one that we know, if we believe clinical variables, we know that this is pretty misclassified and all over the place. So I have a little bit of a hard time interpreting this. I'm not sure we should exactly interpret it because of the misclassification, and probably very differential in some way. Interestingly, interestingly, the results in the overall cohort, just using the claims, is suggestive of a protective effect of iron. It's reducing mortality, short-term mortality risk, which really doesn't make a lot of clinical sense, or biologic sense. There's no correlations here. We don't have a gold standard. We don't know what the true effect of treatment is, so we need to assume that the estimates that are coming from the clinical cohort, all the clinical variables are best estimates, and that may not be true. So one assumption. We're also assuming that the clinical exposure measurement is best. I'm looking at a very specific data system in a very select population. So I don't know if this has any broad relevance. But anyway, these are methods, and these are sort of steps that you might go through as you start to look at these kinds of databases here in-house. So in this particular setting, we saw substantial misclassification of exposure. I think that was one of the main things that we found. So we needed to use the clinical data to get a good measure of exposure. We also found the clinical data provided better confounding control. So I think many of the labs that were available in the clinical data were important. And there was very little selection. The data cohort was very similar to the overall population of dialysis patients in the U.S., so we didn't really see that the selection weights made much difference, but it may be that in other settings they would be more important. I'm kind of interested now, as I was sort of working on these, to try to better understand whether the exposure misclassification in the clinics is differential in some sense, sort of to look at whether patient characteristics predict whether or not the dose will be misclassified, in the sense of whether there may be some sort of differential misclassification there. So I'm presenting work that my colleagues Alan Ellis and Leah McGrath have done a tremendous amount of work on. Also, this has been a lot from the involvement of UNC ESRD EPI group, and some of this work was funded by ARC through the DECIDE Center. And we talked about some of the other aspects of this project, but one of the things we've also looked at is basically the same thing, trying to assess the effectiveness of the influenza vaccine. And letting we actually have a really good negative control. We have the truth is, because we can look at the effect of the vaccine on mortality before there's flu in the community. So we know that the vaccine should protect you when there's no flu in circulation. So we have this kind of great negative control outcome there. And unfortunately, we weren't able to get the confounding to go away. We thought that using the clinical data, we would be able to deal with all the strong confounding that's known to exist in that setting, but we weren't able to do it. But what we could do is restrict the cohort enough. We could essentially require patients not to have any hospitalizations after the vaccination. Normally, you would be nervous about essentially restricting on something occurring during follow-up, right? It's kind of a no epidemiology. But here we know that the vaccine can't have any effect on things that are reserving until there's flu around, right? So you can extend the baseline period past the date when the vaccine is given. So it's kind of an interesting idea that you can kind of control for the future to you can put things in the future to get a better reduction in confounding bias. But that works a lot better than any kind of statistical adjustment. So in a way, we can't lose by the fact that study design may be one of our most powerful tools for dealing with confound, the comparative user design that Hill was discussing earlier. So I'll stop there.
Thanks. Questions? Alan? No?
Okay. I one that I may have missed. So how did you join two databases? Did you just, because of Social Security numbers, will you just be able to do that? Have to do
That's
some?
a good question. It's a little bit of a dance because we limited databases from both the VITA and the USRDS. So we have a scrambled identifier and we have dates, and that's all. So DaVita, of course, has the names and Social Security numbers. Medicare has the same stuff, but Medicare gives us that information. DaVita won't give us that information. We basically had to use a third party that received, you know, a DaVita with the scramble identifier that we have, and then all the direct identifiers, and CMS gave them something analogous, and so they got back a crosswalk that has one scrambled identifier and another scrambled identifier, so we can link these two essentially de-identified data files. But that's, I think that we're going to have to do stuff like this to get these data files linked.
That's much better than having that third party and just trying to hope that you've matched the right people to the...
Yeah.
So it's just an example of data distributed network in a way that it's more than EMR and administrative
Data, right? You have this robust,
It's just one, yeah, it was two data sources on the same population. So I usually think of distributed data networks as, United and across the, a whole bunch of different databases that are, we're doing the same analysis. This is all one population. We just are getting data from different.
Some of the subjects in the data set, they do have third-party payer sources.
So I had that in a footnote. I didn't really get into it. So we had to restrict to Medicare as primary payer to full capture of data in the claims. So if you have end-stage renal disease and you have private insurance, primary payer for 2 years, and then you would go into the Medicare program. Medicare is primary payer, so it's not fully generalizable to the dialysis population.
You'd be able to refresh the data?
It's got to do crosswalks. We're going to do this every year. We have to go through this process. It's very time-consuming, but we get another year of DaVita data, another year of CMS data, and then we built the crosswalk, and maybe a little bit more automated, the whole process.
Thank you.
A quick follow-up to that for a second. What's the lifespan of a patient in this kind of end-stage disease? That last answer is sort of...
No, unfortunately. They have a 3% annual mortality rate in the U.S., which is higher than most metastatic cancers. So we don't. There are few patients that have years and years of data.
So that period, those first 2 years where you have a compromise, you're losing a significant part of this population, probably.
In fact, the first year is where it's highest. There's really a very high mortality rate the first year. So, in fact, we all wind up kind of excluding those guys because we don't have good sort of baseline data.
Thanks.
Okay. So,
This is a more general question about the previous speakers. It was mentioned that there's considerable cleaning of data before the EMR data. Do you have sufficient documentation of what has been done by the EMR vendor to take this into account?
That's why we are planning on and that's why we are planning on having more validation done in-house to make sure that data is clean, and that's to depend.
Some of the cleaning that has been done, you cannot recoup because it's already done.
Right.
So you need the data.
Yeah. So far, when we've been working with their data, we've not found such discrepancies. For example, like the one that I stated, whereby the admission date is after the discharge date, such. But that's what we hope to be looking at.
pregnant men.
I have a quick question. Can I, as a private sector, get access to that, or do we have to work with you in terms of for the studies? And
Actually, you could buy all these data and have them here. The rules are a bit mysterious to me, but I think the CMS data are different. So you couldn't purchase the fee-for-service general Medicare data, I think. But you could buy the CMS data from the ESRD population. Anyone then can order those with the data, with the IRB approval and a data use agreement. The data also can be purchased, so you could build the same database here.
Okay, we take a break. Come back at 2:30. Do the last session. We can get out on time. Okay? I know.
And I didn't think there would be with the whole form.
Yeah, usually there is this, but you never know when people get in a room with people they don't know as well. Right. I need to cancel that. Can you ask her for me to cancel it? Can you send her a message? My iPhone is dead. Okay, thank you. See, I'm looking for your slides. You sent them this morning? Or?
Yeah, and break. Wait, I have trouble accessing.
Here you go. Here it is. It's heterogeneous.
No, that's the first one.
1143 is not the right one?
That's yesterday.
Oh.
I went back and added in stuff.
Non-inferiority. There you go. Right. Should be up. Yes, bring it up.
Can you just make sure? Oh yeah, it has 23 slides. I just want to make sure it has that.
Yep, you're set. Yeah. Good. Yeah, Rachel's going to introduce y'all's session.
And we just switched it.
Yeah, that's
And if we don't know.
I don't even know if it works. I think everyone's in. It's funny when I return to where, like, I'm just going to the more the merrier. I never thought about free camping. You're not going to get free camping. I'm having trouble. This charger's not working, and I'm wondering if it's what. It's going to do better. I'm almost out. I don't like going to the airport and walking without a phone.
I was going to ask you, would you mind Should I spot? Good, have nothing